Imagine you are a health systems leader or disparities researcher who has just been given a budget and a mandate to reduce healthcare disparities within your health system. How would you know what to work on or where to focus? In addition to involving stakeholders and community perspectives, you might want to find quantitative data on a metric that matters to patients where there exists a disparity. That's where our dashboard comes in. Upon opening it, we'll first select the setting and campus of our target population. We can then choose the outcome and social determinant of health for which we are interested in finding a disparity, in this case, length of stay by race. The dashboard then uses this information along with the patient data itself to generate a comprehensive graph with the average length of stay separated into racial groups. In this case, the graph shows that Black patients have an average length of stay of 98 hours, which is at least 8 hours longer than the next closest race, so we can dive deeper to find a course of action to address this disparity. Based on the information in the initial graph, we select Black for our disadvantaged group because we know that Black patients have disproportionately longer lengths of stay on average. We also might want to figure out which subpopulations contribute the most to our disparity, which could influence where we decide to focus and budget our resources. For example, existing research has shown disparities in COVID-19 outcomes by race, so we might think to start there. Once we enter this information, the first graph again provides us with average length of stay for each race, but this time separated by billing diagnoses, which we selected as our subpopulation. The most common of these billing diagnoses was COVID-19, with 674 admissions. But here, we see that Black patients and white patients had nearly the exact same average length of stay, suggesting that in this setting, COVID-19 may not be the right focus area for reducing the overall racial disparity in length of stay. We can also see this information in table form, and the input at the bottom allows us to select from a total of 4 prompts, each of which has associated graphs and tables to provide the information alluded to in the prompt. We can also see what the data would look like if every billing diagnosis was perfectly equitable. Now, instead of focusing on COVID-19, where we didn't find a large difference, let's try to determine which billing diagnoses contribute the most to the racial disparity in average length of stay, using our actual minus equitable metric. Once we click on Most Inequitable, we see the billing diagnoses with the largest length of stay disparity by race on the first graph. For example, among the 68 sepsis unspecified organism cases in the dataset, Black patients had an average length of stay of nearly 600 hours, compared with only 353 for white patients. The second graph shows the difference between the actual and equitable total hours of length of stay for Black patients with each billing diagnosis. When we click on any of the bars, we can see the under-the-hood calculation for each billing diagnosis. The average length of stay for all 68 patients with sepsis unspecified organism was approximately 406 hours. If the average length of stay for sepsis patients was this value for every race, we would expect the 20 Black patients with sepsis to have approximately 8,128 total hours of length of stay. However, these 20 patients actually had approximately 11,584 total hours of length of stay, meaning that Black patients with the billing diagnosis of sepsis unspecified organism had over 3,455 total excess hours of length of stay when compared with what the equitable value would be for that diagnosis. So this might be an opportunity for improvement.